Thanks for listening to the Pharmacy Podcast Network.
We have an aging population taking more medications than ever before. On this podcast, I will interview experts in geriatric medicine to gain insight so we can provide optimal care to patients in their golden years. I'm your host, Dr. Tamara Ruggles, and this is the Geriatric Pharmacy Focus. Hello, listeners. Welcome back to the Geriatric Pharmacy Focus. I am so excited today to have a wonderful guest, Dr. Singping Chow, who, if you follow him on LinkedIn, you know he produces some awesome content on pain management. And about a year and a half ago, I had Dr. Laura Meyer-Junco on talking about opioid stewardship, and she briefly brought up the Butrans patch. And I had not seen that in my nursing home patients as a way to manage pain. And she kind of opened my eyes, I guess you could say, to the Butrans patch and buprenorphine in my nursing home patients for pain management and kind of the benefits that that medication brings. So I've been looking more into it and then found Singping on LinkedIn, who also produces awesome content on buprenorphine and has kind of helped me with some of the guides he has put out. So if you're not following him on LinkedIn, do that now. But he is a pain management specialist at the VA, at the Bay Pines VA in Florida. And so, Singping, welcome, and please tell us a little bit about yourself.
Thank you. Thank you, Tamara. And thank you so much for introducing and inviting me to the podcast. I'm very excited. So my name is Singping. I am an inpatient pain management pharmacist. So I just want to make a little disclaimer before I go into the podcast today. So everything that I'm mentioning today will be the opinion of my own, and it does not reflect any opinion to my employer. So with that, I want to say that my current role has been rapidly evolving over the last 2.5 years. So when I first started my position, I was having some sort of consult structure in place. And at the time, I was helping out physicians and patients who are really struggling with their pain management. And so after some time doing more of a consult-based service, I realized that the reach was not enough. So at that time, I was like, I need to really get almost like deeper into the system and really see how can I help even more. So after I, realized that the consult service isn't getting as much traction, then I started doing table rounds with the hospitalist. And at that time, after I started doing that, I really gained more appreciation and understanding of the practice, really the granular practice and how they think through pain management, how do they approach medication management and opioids. And after that really opens my eyes more, because only when you understand how they practice, how they see opioid management, then you can actually address those root cause and provide the education. So that was my transition from consult to more of a table round with hospitalists. And then afterwards, I feel like I can do even more than just rounding with hospitalists. And now I am transitioning more to doing opioid stewardship and really looking at like a systemic level in the internal medicine wards, and how can I address the IV opioid use, and how can I really optimize the opioids and non-opioids for patients for better care. So it's been rapidly evolving just in the last 2.5 years, and I'm very excited to do what I'm doing, because the directions and the potentials and possibilities are limitless. So if I can share 3 things that makes us important and really why we're such an integral part to the healthcare system, and how we can really address the current opioid crisis in the current landscape in America, I would say The first thing is that many of us can recognize the opioid dose, but not many of us, let it be clinicians or pharmacists, will be able to comment or clinically evaluate a dose. And what I mean by that is when I precept pharmacy resident or medical resident, I love asking them this question: how would you comment a certain opioid dose? And I love using oxycodone 30 milligrams because that's kind of like moderate to a high dose as a single 30 milligram dose. But I want to see what kind of rationale or what kind of reasoning do they have to when I ask them to comment on it. And so for the most part, I would get answers like, I'm not sure. And when I do get answers like, okay, yeah, it's a high dose or medium dose. And then when I dig deeper and when I ask them, why do you think it's medium or high? And then the rationale is usually, oh, because that's what I'm being taught. And what I was really hoping for was, they can really share more insights about, oh, because that's the conversion, or because of this pharmacokinetic or dynamic, or more of an in-depth rationale of that. But unfortunately, that's not what I see. And that brings me to the second point, that why it's so important to have us, be part of the team, because with the current education system, let it be medical school or pharmacy school, I don't think that the education is enough we're not giving enough training to allow physicians or pharmacists to, like I say, clinically evaluate the opioid dose. Because I think for the most part, from what I hear, is that most students and residents, they only get maybe like a week of training, and that's it, like a week of lecture. But what really is 1 week of lecture, right? And what we're dealing with is really, with the opioid pandemic and opioid crisis, we're looking at high opioid doses and really sophisticated opioid doses that sometimes it's, where it's kind of unquestionable practice, right? And so we need almost like a sharper eyes to address those problems. But with that little training, I don't think that's enough. So that's kind of what we're kind of where we're at, unfortunately. And the third thing that I want to share as to why I think why we're crucial in the current healthcare system, kind of looking ahead with everything going on with AI, right? Because there's a lot of buzz with AI currently, and how AI can be really integral in a lot of healthcare areas. So I like to think that I do not think that AI will likely replace pain management or palliative care pharmacists, because humans are we're very social animals. We want that human attention. We crave for that human interaction. So until the point where AI or technology is so sophisticated to a point that it can almost replace, the human interaction like 100%, I don't think that we will be replaceable. And even, I would say, even at a point where because I've seen news about the humanoids and it's something down the pipeline, right? Even when the time where the AI technology is so sophisticated that it becomes the mainstream, that means that the real human interaction provided by pain management pharmacists is even going to be so rare. And the world operates with scarcity. So I think that there is always going to be a role for us, because that human interaction, I don't think, is replaceable. So with that, I think our role is so crucial. Our job is likely going to be evergreen, at least for the next 10 to 15 years. So that's us and that's me.
Yeah, it's a good day to be a pain management pharmacist. And I agree with so many things you said. Yeah, I don't remember how long our pain management, lectures were in pharmacy school, but I know I still have a lot to learn, especially in regards to buprenorphine. I don't really remember learning about it that much. It's been recently I've been learning more and more about it. And you mentioned the relationships and joining the round tables, and that's huge because if you develop a relationship with the provider where they can trust you, then they're really going to be willing to reach out to you, get recommendations, ask for that consult. So huge. So let's get into buprenorphine. I'm so curious what you are going to teach us today. First of all, can you give us a bit of an overview, mechanism of action? Just a little bit of overview of buprenorphine.
Absolutely. So there's so many things about buprenorphine. I feel like, sometimes I like to joke about it. I can talk about it for hours. But if there are some high level highlights about buprenorphine, let's start with this fact. Okay. So because so many of us would confuse with buprenorphine, it's the same as Suboxone, and that's false. And I hear it all the time, right? And so when a patient is on buprenorphine, then either pharmacists or physicians, they would say, oh, the patient is on Suboxone, but they're two different things. I like to think about using this analogy is that like all apples are fruit, but not all fruits are apples. So we can think about that the buprenorphine is the fruit. It's more inclusive, while the Suboxone is only one type of fruit, which is apple or grapes or whatever you want to think about it. So that's very important because with buprenorphine, there's so many formulations. There's so many dosage form. So I like to call it just buprenorphine just for simplistic purpose. So that's very key. So when it comes to explaining buprenorphine, I think there are two major audience to explain it to. The first group is the patients, and the second group would be the physicians and clinicians. So the reason why I think it's very important because in the end of the day, we want to get that ideas across to patients. We want to let patients know in the most simplistic and understandable way so that they can have buy-in. And unfortunately, at least what I've been taught in some CEs or talking to colleagues, sometimes we would say, oh, we have to emphasize that this to patients that buprenorphine is a partial mu agonist so that it works better. And to me, I think that's false because at what life circumstances do we even use the word agonist in life unless right? Unless you're a nerd or you have a very fancy, very deep chemistry background, then maybe you would use the word agonist in your life. So when it comes to explaining buprenorphine to patients, I try not to even use the word partial mu agonist because all that the patient can register is the word partial. And they're not going to have any context with, let it be mu or agonist, they're not going to know. So what happens if you tell a patient that it's a partial mu agonist, then all that their mind will be anchoring to is the word partial. And that means you have to almost spend extra time to explain and kind of go back to the drawing board, telling them, oh, it's not really partial. It is still a very potent and great medication. I feel like that is almost setting up yourself for failure. So when I do explain it to patients now, I feel like after failing it so many times, when I used to do that myself as well, and after getting so many googly eyes, I'm like, no, let's just not tell them it's a partial mu agonist. I would just say it's a opioid that works differently than the conventional opioids. It is still a very potent and strong opioid. It's just that it works differently, and then that way it's way easier for them to digest when they just hear the most simplistic form. Now, the other thing that I think it's also beneficial for patients to understand buprenorphine is that buprenorphine is such a hard word to pronounce. I don't know if you find it as well. And I just call it bup. I tell patients that, hey, it's a medication called buprenorphine, but for simplistic purpose, you can call it bup and we will understand. And I know that for some of my colleagues, we call it bup as well. Because I think that when we are able to associate, when we can say that name, then it's easier for the patient to be adherent to the medication. It's easier for them to, know and understand that medication. So I think that's very important. So That's everything about patient side. And then, with the clinician, explaining to clinician, now we can actually use the word, it's a partial mu agonist. So and before I even dig deep into, the partial mu agonist and the mechanism, there's one very good resource I want to share with you. It's a paper by Dr. Lynn Webster. It's published in 2020. If you type his name, LYNNWEBSTER, Dr. Lynn Webster, and type buprenorphine, that paper would come out, and it's such a good paper. It's a very good overview of everything buprenorphine, and I highly recommend that. I share that to residents, students, because it's a very good resource. So one of the biggest misconception with buprenorphine and being a partial mu agonist is that it is partial, it's less effective. But that's not true. Because when we think about, the potency of an opioid, it has more to do than just the fact that it's a partial mu agonist. So when we think about partial mu agonist, is that when the researchers look at buprenorphine and compare to like a full mu opioid, for example, let it be morphine or oxycodone. So those are all done in vitro. And so it does show that it's partial. It does not induce as much of an effect in vitro. But when it comes to potency, there's more than just a full mu or partial mu, because there's also a lot to do with how much it binds the receptor, the affinity, and how long it stays there. So with buprenorphine, it's very interesting because buprenorphine has very, very high affinity to the mu receptors, and it also lingers. It sticks to the receptors for a long time. That's what is part of the package that makes buprenorphine a very, very potent opioid compared to, let it be, morphine or oxycodone. So it's very important not to think that just because buprenorphine is a partial mu agonist, there isn't anything partial about that. So that's very key. Now, the potency with buprenorphine on research, sometimes there are some mention about it being about 20 to 50 times more potent compared to morphine. And there are some mention that it can be as potent as 100 times than morphine. And if I give you more context, Tamara, that fentanyl is 100 times more potent than morphine. So that means if we take the upper limit of the potency of buprenorphine, which is 100 times. I know some people would disagree because it's more so like 20 to 50. But if we take the upper limit, that means that it can potentially be as potent as fentanyl. And we can talk more about the conversion later. But that's why, with buprenorphine, it's really not partial. It's quite potent if we look at how potent it is compared to morphine and how it's relative to fentanyl. One last thing I want to mention about buprenorphine is that it has what we call a kappa antagonistic property. And so this is very interesting because we know that when patients are on chronic opioid, there's more association with depression. And that's very well studied, and from anecdotal experience as well, is that when patients are on chronic opioid therapy, a lot of times there is depression and other mood disorder really induced by the full mu opioid. Now, there are actually studies that look into buprenorphine because of that kappa antagonistic property. It actually can lessen, it almost helps with the depression. So in our practice, when I work with the physician in the outpatient setting, what we saw anecdotally is that when patients transition to from full mu opioid to buprenorphine, sometimes the patient will have better mood and their energy is better. And because really of that, maybe it's there has to be something to do with that kappa antagonistic property. So there's a lot of interesting facts about buprenorphine. That's why it's such an exciting drug.
Yeah, I love learning about it and especially the benefits. And if you can, switch a medication that would improve a patient's mood, potentially reduce polypharmacy with the need for an antidepressant, that's a win for sure. So you've talked about
Yeah.
one benefit of Bupe.
Yes, do.
Let's talk about some of the other benefits of
Yeah.
using it over other opioids.
Absolutely. So with buprenorphine, there are a couple of interesting benefits, or we can think of it as almost like a less side effects, because I like to think less side effects is still a win. So, the first thing with buprenorphine is that there is almost like a less testosterone drop, even though that testosterone kind of less effect to the testosterone. It's really from small studies back in early 2000. So in that study, they look at Suboxone, which is a dose that is usually for patients with opioid use disorder or dependence and sometimes complex pain. And in that study, they look at Suboxone compared to methadone. So what they saw is that there is a statistical difference in terms of testosterone decrease. So, and with that, the buprenorphine group has less testosterone drop than methadone, meaning that methadone is going to cause more testosterone drop. Now, the other aspect of that is that in that study they also look into libido, and that difference is quite significant. So they saw that in the about 20% of the patients um, in the buprenorphine group, there is a decrease and influence of the libido, and in the methadone group, there's almost like 80% or something like that. So the difference is huge. Now, with that caveat is that because this study, they're really looking at buprenorphine in a higher dose, because when we look at the buprenorphine that comes in less, in lower dose like Butrans and Belbuca, I would say it's kind of hard to translate that to like a lower dose buprenorphine product. So take it with a grain of salt. So there is definitely some studies out there that look into the testosterone influence. But again, there's some caveat in there in terms of what patient population group they study at, and also the dosing, because dosing is everything when it comes to opioid management. Now, there are also two big other side effects that buprenorphine has less of an effect compared to the full mu opioid or the conventional opioid. So the first one is constipation. I love talking about constipation with patients because you know what, Tamara? A lot of patients feel that talk about poop or talk about bowel movement is so embarrassing. I don't know why.
Mhm.
Yeah. And so sometimes, and just from my experience, is that patients don't talk about it until things are, hitting the roof. It's like day 4, they're not having a bowel movement, and something is going south, and they tell me. So it's very important that you keep track. So I like to tell patients that I'm not a bowel movement police. 1 to 3 days, I'm good, because again, just like pain management with constipation, there's also some subjectivity with that. It has to do with their subjective feeling of whether or not they feel backed up. And so there's some subjective factors in there. And everyone has their own bowel movement pattern. So everyone's different. But I like to just keep it very broad and general. I tell them, 1 to 3 days, I'm good. 4 days, you got to be more watchful. In 5 days, probably we got to do something. So it's important to kind of gauge the baseline and then, let them know kind of what kind of ballpark that I'm looking for. So with buprenorphine, there are studies that look at the incidence of constipation, and they compare that with morphine. So what they found is that buprenorphine is associated with less constipation. And perhaps there is some mechanistic explanation to that if we want to get to more of a biochemical reasoning of that, is that there is a mechanism called the beta arrestin. And this is a very interesting mechanism. Once the opioid binds to the mu receptor, there is this part of a cascade or a cellular response called the beta arrestin. And this beta arrestin is proposed to be doing it has to do with a lot of the side effects with the opioids. So part of that is the constipation, and the other part is also the respiratory depression. So all that has to do with the beta arrestin. And because of the very fact that buprenorphine is a partial mu agonist, so what scientists are postulating is that because of almost like a partial effect, that it doesn't have as much of an effect to this side effect cascade dictated by the beta arrestin. That's why we're seeing less of a constipation side effects from buprenorphine. Now, there is the last one, that is why buprenorphine is being more and more promoted in nowadays landscape, is really because of the fact that it has way less respiratory depression compared to the full mu opioid. So this one has to do with what we call the ceiling effect of the buprenorphine. And it's due to the partial mu agonist effect, that there is a ceiling effect that comes with it. So what we mean by ceiling effect is that after a certain dose of buprenorphine, then it almost like plateaus out. So the more buprenorphine you give, it's not going to cause more respiratory depression. Now, there's one catch to that, because I don't want everyone to almost like go to feeling almost too safe with buprenorphine, because there is one caveat with that, is when patients are on buprenorphine with, for example, like a benzodiazepine, it can, like in that combination itself, can also cause that, respiratory depression. And there is actually a study that looked into the overdose death reports. And when they look at patients who are overdosed on purely buprenorphine, the incidence is very, very low. But when they look at patients who are on buprenorphine, but they also found other, sedatives like benzo or other sedatives in there, that's where they saw almost like a substantial increase with the overdose in those cases. So that's why it's very important that just because buprenorphine, yes, let's acknowledge that it has a safer, side effect profile, let it be constipation or the respiratory depression. But it's still very important to make sure that we are trying not to use as much of a benzo. And if you do, make sure that they get the naloxone and the close monitoring. So that's very, very important.
Yeah, I think that makes a lot of sense. And those are perks, especially when we're talking about our geriatrics. How many of them are already constipated before you put them on any sort of pain medication?
Yes.
And so we do have to be vigilant about being proactive, monitoring it, starting something. So I love that benefit of buprenorphine, and especially, the respiratory depression, because our older adults maybe already have, less reserve. They might have COPD, long-term asthma, and what? They're probably not exercising and taking a deep breath very often, and, doing that kind of respiratory therapy or exercise. So those benefits are huge. And then remind me, with buprenorphine and kidney impairment, liver impairment, is there any precautions that need to be used there, or can buprenorphine be used for kidney and liver impairment?
That is such a good question. It's almost like $1 million question, because, because you know what? Like with buprenorphine, I want to say that when it first came out in the late 60s and almost in 70s, there's, a lot of studies. When it first came out, it's in the IM formulation. And then after, I would say probably in the 90s, where there's still a lot of research. And then there's almost like a gap period where it just almost like stopped. Like everything is about opioid use disorder or dependence, and these studies on pain management is lacking. And so there is almost this period where we don't have a lot of data, and now we're slowly picking back up. But then now that we're slowly picking back up, and then we're almost missing a lot of data in the interim. So I would say that's such a good question, because with the renal dysfunction and the hepatic dysfunction, there is more data in the hepatic dysfunction population. So what we saw is that even when we look at the drug label itself, it says that when patients have hepatic dysfunction in the very severe hepatic dysfunction group, there is almost like a 180% of serum level in AUC increase compared to healthy subjects. So in those patient population, we would recommend to, going back to the first principle of opioid dosing is start low, go slow. And so that I feel like with the hepatic dysfunction group, there's more data. But one of the very interesting caveat is that with buprenorphine, because it has so many formulation, one formulation that is actually recommended against in the hepatic dysfunction group is the Suboxone. And so the buprenorphine in hepatic impairment, yes, we can start low, go slow, and do more monitoring. But specifically with Suboxone, what happens is that because Suboxone has both the buprenorphine and naloxone co-formulated in there, what happens is the problem isn't the buprenorphine. The problem is the naloxone, because with hepatic impairment, the naloxone is really not cleared. So if you look at the drug label of Suboxone, it would really say recommend against, like don't even use it, because the problem being when our body is not clearing the naloxone, then the concern is that they will be causing more withdrawal symptoms. It's almost like the naloxone is in the system for too long, and it will almost like causing this constant antagonist effect while there's the buprenorphine in the system. So if we look into the package insert, that is one formulation that it would be recommended against, and that is the Suboxone. And with the renal dysfunction, that group, wow, I want to say like there really isn't a lot of data. I recently published a paper with Belbuca use in end-stage renal disease. It's a case report. And I do that case report because I really want to tell people out there and really start studying in this patient population group, because we don't know as much. When we look at the UpToDate or lexicon and go to the kidney impairment and see if there's any dose adjustment, they would say no adjustment. But I am a little bit partial and not quite sure about that, because we know that with renal impairment, there is a active metabolite from buprenorphine. It's called norbuprenorphine. Norbuprenorphine is still considered active if we look into the literature. And in the renal impaired patients, that norbuprenorphine can still be accumulated. So now, is there a lot of studies and case report out there saying that buprenorphine should not be used in renal impaired patients? No, because if we look into, if we do a PubMed search or Google Scholar search and search for renal impairment and buprenorphine, they actually recommend, in some of the review articles, they recommend to use buprenorphine in renally impaired patients. But if we go to the references, we saw that a lot of that is really referencing in, small studies, case reports. So that's why in the renal patients, I feel like the data is not enough. But am I going to say that we should avoid using it? No, I think that we should start using it more, but in a more careful manner, so then we can start to gather more data. Because I feel like at this trend of the opioid prescribing landscape nowadays, I feel like the buprenorphine is going to get more and more popularity. And this is the time we want to really start thinking about and really start using it in those patients, so then we get an even more clear experience in what we're going to do in the renally impaired patients.
Yeah. Yeah, always with geriatrics, right? Start low, go slow, monitor.
Absolutely.
So you can
That's
use the
principle number
same.
one.
You got it. So as we're talking about dosing,
Yeah.
that's one thing where I feel like is a gray area with buprenorphine. Can you just talk about dosing and conversions from other opioids to buprenorphine?
Yeah, and I would say conversion and dosing is another area that is a little bit ambiguous, okay? And because again, the with how buprenorphine works, being a partial mu agonist, is that its conversion is not as straightforward as we think. Now, I like to think of the conversion of buprenorphine as there are two ways to think through that. There is a theoretical way, and there's also a practical way. So let's just start with the theoretical way and kind of going back to the drawing board of how buprenorphine is about 20 to 50 times more potent than morphine. And in some other cases, in the upper limit, it can potentially be 100 times more potent than morphine. So with that in mind, I've seen some dosing guides that would almost convert the buprenorphine, the Butrans patch. They convert the Butrans patch almost very, very similarly to the way we convert to the fentanyl patch. Maybe my postulation is that it's really due to that potency, how buprenorphine can potentially be as potent as fentanyl. So I have seen that. Now, the a lot of times I still go back to the dosing guide. There's a little table that is provided by the Belbuca manufacturer, but there is some catch to that. I feel like there is everything with the conversion is there's some sort of caveat to that. Because if we look at the how we're going to convert patients who are on 90 to 160 oral morphine equivalent, they would recommend to convert them to 300 microgram twice a day Belbuca. But if we think about 90 to 160 or morphine equivalent, that's a huge jump, right? And so I would wish that if it's, for example, like 90 to maybe like 120, sure, but 90 to 160, then just from that range, that it's almost like it's too imprecise to put our fingers on how to really convert from the full mu opioid to Belbuca or Butrans. Now, the practical side of it is really where it gets interesting. With buprenorphine, there is something that is quite unique to itself, is that for some reason, it has to do with, again, the fact that it's a partial mu agonist, is that it can cause what we call precipitated withdrawal. And this is so interesting that likely because it's the intrinsic activity because of the partial mu agonist. So there is this phenomenon called the precipitated withdrawal. And so it happens when a patient has been on full mu opioid for some time, and sometimes if they're on high dose. And if we start them on let it be like a Suboxone 2 milligrams or 4 milligrams from the get-go, it can cause what we call precipitated withdrawal. And that's why there is more and more studies starting around, I would say, in the last 5 to 10 years. That's why people start to really promote this idea called microinduction. Have you heard of the microinduction so far? With
No.
buprenorphine? Yeah, it's a very interesting thing. So the idea of that is because now that we know if a patient is on this full mu opioid for some time, and then you start them on like a Suboxone, which is the milligram dose, then it can cause that precipitated withdrawal. So the idea of the microinduction is that we want to sneak in, we slowly introduce that buprenorphine into the system with the hope that it's not going to cause that precipitated withdrawal. So that's what we call the microinduction. It's almost like it's very sophisticated. It takes more time compared to, a conventional conversion from like a full mu to like a Suboxone. Those when we convert from full mu to Suboxone, those cases are mostly for patients who have opioid use disorder, dependence, or we call it like a complex pain picture. Now, I do have patients where they're on just maybe like, oxycodone, 10 milligrams, 4 times a day, or hydrocodone. And then when we convert them to buprenorphine, let it be Belbuca or Butrans, what I would do is that I would start low and go slow, because something to really bear in mind is this precipitated withdrawal side effects. It's kind of hard to predict. So with buprenorphine conversion, that's why I call it the practical side of it. Is it's not as straightforward as going from one to another, like from morphine to a Dilaudid. It doesn't quite operate like that. Now, the one last thing I want to really talk about with the conversion, right? Because when we think about conversion, one of its use with opioid conversion is to determine the PRN dosing of the opioid. Let's say, for example, someone is, on certain amount of oral morphine equivalent, and then they break a hip. And then what do we do with that, with that breakthrough pain, for example? Then we will start to think about, okay, we will, tally up all the total daily oral morphine equivalent, and then do our 10 to 20%, 10 to 20% of total daily dose, and then go from there. And then that's our PRN dose. But here's the thing. With Suboxone, okay, which is the milligram dose of buprenorphine, we know that doesn't quite apply. And the reason why is because when we really look at, if we kind of go back to the theoretical potency and conversion argument of buprenorphine, right? We know that it's about like 20 to 50 times more potent than a full mu opioid. But if we really use that conversion and look into how much oral morphine equivalent with like Suboxone or buprenorphine in milligram dose, if we really do that math, theoretical math, it can come to maybe like hundreds of oral morphine equivalents. But when in practical setting, let's say someone is indeed on Suboxone, let it be 12, 16 milligrams, and they do need to have to undergo some sort of surgery, do we do the 10 to 20%, meaning that if they're on hundreds of theoretical oral morphine equivalent, do we give them like 100, or 50 to 100 per PRN dose? We don't do that, because from my practice, anecdotally, I would start with oxycodone 10, maybe 15 milligrams when patients are on Suboxone. So when we think about that, really, like, does that PRN 10 to 20% apply to Suboxone? We don't quite know. That's why there is still a lot of things we don't quite know. We can't really just use what we know about opioid conversion and directly apply to buprenorphine, let it be the microgram dose or the milligram dose, because the conversion is not as straightforward. And we also know that the PRN calculation doesn't quite reflect from what we have been doing with, let's say, the full mu opioid so far.
Yeah, I love buprenorphine for all the benefits. One of the negatives is certainly the dosing, because every time I look it up, I'm like, oh no, I gotta ask somebody, because I don't know what I'm doing. But the great thing is you can start low and titrate up based on, the patient's pain. So is it complicated? Yes, but you can change the dose fairly quickly, right? Like, you don't have to let them be on that dose for too long before you can titrate up.
Yeah, so if we think about like the Butrans, there are multiple ways that with different formulations, there are different dose increase strategy. So yes, it would recommend, you have to wait for a few days to increase. But if we think about I know this is really off-label, and this is, again, it's anecdotal experience, is that because buprenorphine, it does have a long half-life, and so we do really want to let it sit in the system for some time before we increase. So that's one thing about buprenorphine and dose increase, is that we don't want to increase it too aggressively. Think about it almost like methadone, right? Because methadone, we know that it has a very, very long half-life. And if we increase it every day, that's where, things can happen. But I would say, I would challenge that notion, is that because we know that buprenorphine has a safer pro-side effect profile, I would say that you can probably go more aggressive. You can increase it more often compared to, let's say, a methadone. Methadone, we absolutely do not increase it unless it's 5 to 7 days or sometimes even longer. But with buprenorphine, I think you can do it in a shorter amount of time.
Yeah. I think I read 3 days is that right? Titrate after about 3 days.
Yeah, something like that. But something to think about is that it really depends on your on the setting where you're managing it. If it's outpatient, right? If it's outpatient, we have more grace to, kind of wait it out, monitor, and do things very slowly. But if you are doing it in an inpatient setting where things are definitely being monitored, everyone is watching like a hawk, you can definitely have more grace to increase it more rapidly than it sets in the 3 days, and I think that's safe because of that respiratory ceiling with the buprenorphine. So it kind of depends on the setting where you're at.
One thing I love about the Butrans patch is for my nursing home patients who aren't, their pain isn't controlled by the tramadol or the hydrocodone, but they don't really need to go to a fentanyl patch or an oxycodone. You can use that Butrans patch for even an opioid naive patient at the 5 microgram dose, correct?
Yeah, because like if we think about the Butrans 5, and if we convert that to the oral morphine equivalent, it's a very baby low dose. And so I like to, because if we think about it, how we convert almost like a fentanyl patch, then because we kind of drawing the similarity in potency of the upper limit of buprenorphine and fentanyl. So the way we convert fentanyl in the most, traditional way, if we go back to how Dr. Lynn McPherson in that opioid conversion book, we multiply that fentanyl patch dose times 2, and then we get the oral morphine equivalent. So meaning, if I give you an example, like a fentanyl 12 microgram patch, if we multiply it by 2, it's about 24 oral morphine equivalent. And if we do the same calculation, even though there isn't an official way to do that for Butrans, so if we do the same math trick to Butrans, which is 5 multiplied by 2, then it's about 10 or morphine equivalent. That's a very, very conservative dose. It's a low dose. So for that argument, that's part of the reason why I feel like you can start it with, even opioid naive patients, because it's such a conservative dose.
Yeah, I love that. Well, I tell you what, I have learned so much today, and there's so much I still need to learn about Bupe. Brett, you've given us a good overview, a good baseline to start learning more. And hopefully, as we use it more and learn more, see the benefits, especially in our geriatric patients, it'll be prescribed more, because I keep talking about it, but a lot of my providers still aren't prescribing it for our patients. And so I do think with opioid stewardship and the lower side effect profile, it will be used more. And so as pharmacists do need to be equipped to know the overviews, the dosings, and things like that. So thank you for sharing your wealth of information. And if people want to reach you, where can they find you, Singping?
They can absolutely go to my LinkedIn page. My name is Singping Chow, and I think there's only one Singping out there. And so feel free to follow my LinkedIn page. I try to share as much of the opioid tips and also patient stories And like I say, the amount of knowledge with just any kind of opioid dosing right now is still lacking because of the training. And so I try to really be more advocate of that opioid dosing realm, because it's so important for us to really start paying attention, not just looking at how we're going to address the opioid pandemic and the opioid crisis, because right now there's a lot of news and a lot of push to address the opioid crisis, let it be the Suboxone management. But I think one of the things that is really missing out is how are we approaching dosing opioid itself? And so with that, I do try my very best to share as much experience and knowledge of that. So I hope that everyone will, learn more through the stories and experience that I share online.
Yes, definitely follow Sing Ping on LinkedIn and you will learn a lot. So thanks everyone for listening. Have a great day.